All right, welcome everyone. We're diving into pancreatic adenocarcinoma today. Now, I know you're all busy trainees, so this is going to be a super high-yield review, hitting all the key things you absolutely need to know about this really tough diagnosis. So let's just start with one number, 9%. That's it. That is the overall 5-year survival rate for pancreatic cancer. It's a brutal statistic, and it's exactly why we've got to be on top of our game when it comes to recognizing and managing this disease. Okay, here's how we're going to tackle this. We'll start by understanding why it's such a formidable diagnosis. Then we'll get into recognizing the red flags, moving from suspicion to staging, developing a treatment plan, and finally, we'll touch on screening high-risk individuals. All right, section 1, a formidable diagnosis. Let's really get into the scope of this challenge. You know, the numbers are they're pretty sobering. In the US, it's a leading cause of cancer death. We're talking about over 47,000 deaths in a single year. And what's crazy is it's not even the most common cancer, not by a long shot, but it is one of the deadliest. And that's because it's so sneaky. It usually presents late, and it's just biologically aggressive. That's why mastering this topic is so important for your clinical practice. So what puts people at risk? Well, you can kind of bucket these into two groups. You've got the modifiable stuff, right? Things like smoking and obesity. But then you have these huge red flags that you need to be looking for in a patient's history. Things like chronic pancreatitis or, and this is a big one, new onset diabetes in an older adult. And of course, a strong family history. Okay, part 2, recognizing the red flags. So you've got the risk factors in mind. Now, what does this actually look like in a patient? What are those classic signs and symptoms that should make your spidey sense tingle? So often, the presentation is this constellation of really vague but persistent symptoms. Your patient might say they're losing weight without trying, they've got no appetite, maybe a nagging abdominal pain that bores right through to their back. But the absolute classic sign, the one that should have alarms going off in your head, it's painless jaundice. The patient turns yellow and it doesn't hurt. That, often with some really intense itching, is a huge red flag. And here's a classic physical exam finding that's pure gold for your boards and for your rounds. Courvoisier sign. So, picture this. You've got a jaundiced patient, and when you examine their abdomen, you can actually feel an enlarged gallbladder, but it's not tender. That should immediately make you think that something is blocking the bile duct from the outside. And the most common culprit? You guessed it, a mass in the head of the pancreas. All right, part 3, from suspicion to staging. Your patient has the red flags, your clinical suspicion is super high. So now what? What are the next steps? Let's map out the diagnostic and staging pathway. The workup here is pretty logical, step by step. First, you need to see it. So you start with high-quality imaging, like a contrast-enhanced CT or an MRI, to get a good look at that potential mass. Step 2, you gotta prove it. Tissue is the issue, right? So the standard of care is usually an endoscopic ultrasound, or EUS, with a fine needle aspiration to get a definitive diagnosis. And then finally, you take all that info and you stage the tumor. Is it resectable, borderline, locally advanced, or metastatic? This staging step is absolutely crucial because it's what's going to guide the entire treatment plan. Now, a quick but really important point on labs. You're probably going to order a CA19-9, and yeah, it'll probably be elevated. But here's the thing you have to remember. It is not a screening tool. It's not a primary diagnostic tool either because it's just not specific enough. So what's it for? Its main job is to help you monitor how a patient is responding to therapy or to see if the cancer is coming back after treatment. That's its role. Moving on to part 4, developing the treatment plan. We've got our diagnosis, we've got our stage, now we make a plan. And this is where that staging we talked about becomes everything, because the treatment can be radically different from going for a cure to focusing on comfort. So you can really think of the treatment strategy as being on two totally different ends of a spectrum. On one end, you have resectable disease. This is for the small fraction of patients who are lucky enough to be caught early. Here, the goal is cure. We're talking about a massive, aggressive surgery, like the Whipple procedure, followed by chemo. Then, on the complete other end, you have metastatic disease, which is unfortunately how most patients present. Here, surgery is off the table. The goal becomes palliation, using chemotherapy to manage symptoms and hopefully prolong survival. This table really sums it up perfectly. Treatment is 100% stage dependent, but I want to draw your attention to that middle category, borderline resectable. This is a really key concept. These are tumors that are kind of stuck to major blood vessels. So for these patients, we get clever. We use what's called neoadjuvant therapy. That's chemotherapy or radiation before surgery. The hope is that we can shrink the tumor away from those vessels and turn an impossible surgery into a possible one. Okay, our final section, screening high-risk individuals. And this is really about the future of early detection. I mean, given how late this cancer usually shows up and how poor the prognosis is, the absolute holy grail is finding it early. And that's where screening comes in. Pay attention here, because this table is unbelievably high yield for your exams. The takeaway is this. Some people, because of specific genetic syndromes they've inherited, have a massively increased lifetime risk of getting pancreatic cancer. We're talking huge numbers, like a 40% lifetime risk for hereditary pancreatitis. So, if you have a patient whose family history sounds like one of these syndromes, like Peutz-Jeghers or FAM syndrome, it's now recommended that they get genetic testing and get plugged into a high-risk screening program that uses things like EUS and MRI. And that kind of brings us full circle right back to where we started. The whole reason this disease is so deadly is because we find it so late. So the big question we're left with, the question that you'll be a part of answering in your careers, is this. Can we use these targeted screening protocols in high-risk families to finally change the story for this disease? Could this be the key to moving that needle on that grim 9% survival rate? That's the hope.